All right, if you're prepping for your anesthesia finals, you know that lung compliance is right at the heart of what we do. It's a critical topic, so let's dive into this high-yield review and make sure you've got it down cold.
You know, it all comes back to this one very real, very practical question. You're there, bagging a patient, and you feel that resistance. Or maybe the ventilator starts alarming with high pressures. That feeling, that stiffness, that is a direct, hands-on experience with decreased compliance. And understanding what's going on physiologically is absolutely key to managing.
So here's our game plan. We're going to start with the basic definition, get into the physics of it all, see how it plays out in the clinic, and then, super important, talk about how anesthesia affects compliance. We'll wrap up with how we can use PEEP to make things better for our patients.
Okay, let's start from square one. First up, defining lung compliance.
So, what is it really? Well, in the simplest terms, compliance is just a measure of stretchiness. Think of a really old, used party balloon. It's super easy to inflate, right? That's a highly compliant lung. Now think about a brand new, thick balloon. You have to blow really hard to get any air in it. That's a lung with low compliance. It's stiff.
And here it is, the formula you absolutely positively have to know. Compliance equals the change in volume divided by the change in transpulmonary pressure. And all that little triangle, the delta, means is change in. So this formula is just asking, for every 1 unit of pressure we apply, how much volume do we get in return? That's compliant.
Now here's a crucial point. The stiffness we feel isn't just about the lungs themselves. We're actually dealing with two separate things, the stretchiness of the lung tissue and the stretchiness of the thoracic cage, the ribs and muscles. Both of these play a part in the total picture.
And this formula shows you exactly how they're connected. It's a reciprocal relationship, which means the total compliance is always going to be less than either one of its parts. If it helps, you can think of it kind of like resistances in a parallel circuit. This is another one to lock away for your exams.
So what's a good number to keep in your head? Well, for a healthy adult, the total respiratory compliance is right around 100 milliliters per centimeter of water. And that number usually comes from a lung compliance of about 200 and a thoracic cage compliance of about 200. You do the math with that last formula, and bam, you land right at 100.
Okay, let's switch gears a bit. Section 2, the physics of breathing. We've talked about what compliance is. Now let's dig into the actual physical forces that are at play.
It really boils down to two main forces that the lung has to overcome to inflate. First, you've got the elastic recoil of the lung tissue. Just picture a whole network of tiny rubber bands that are always trying to spring back. And second, you've got the incredible force of surface tension, which is created by that thin film of fluid that lines every single one of our alveoli.
And this is where we have to bring up Laplace's law. Basically, it says that for any bubble, the smaller it is, the more pressure it takes to keep it from collapsing. Now, if you apply that to our lungs, well, it would suggest that all the tiny alveoli should just collapse and empty into the bigger ones. It would be a total disaster.
But of course, nature came up with a brilliant solution, surfactant. It's this incredible substance that gets right in between the water molecules lining the alveoli and just shatters that surface tension. The result? It makes the lungs way more compliant, it keeps the alveoli stable, and it prevents them from collapsing. It's absolutely vital.
All right, enough physics. Let's bring this all back to the bedside. Section 3, compliance in the clinic. How do different diseases actually change these numbers?
Okay, screenshot this one, folks, because this is pure exam gold. On the left, you've got things that make the lungs more compliant, or floppy. Think of emphysema, where all that elastic tissue is destroyed. On the right, though, is the scenario we see all the time, decreased compliance. This is our stiff lung. The causes are a laundry list of things we deal with daily: fibrosis, pneumonia, ARDS, fluid in the lungs, collapsed alveoli, even just obesity or having a patient lie flat on their back.
And that brings us to the most important part for us. Section 4, anesthesia and compliance. How does what we do in the operating room directly impact all of this?
Now, if there's one thing you take away from this whole explainer, let it be this. General anesthesia is not physiologically neutral. It inevitably, and I mean always, reduces a patient's lung compliance and their functional residual capacity, or FRC. This isn't some rare complication. It's an expected change we have to manage.
So why does this happen? Well, it's really a perfect storm. First, we lay the patient flat, so their abdominal contents push up on the diaphragm. Then our anesthetic drugs and muscle relaxants knock out their muscle tone. All of this squishes the lungs and shrinks that FRC. And to top it off, once we intubate, we bypass the larynx, which actually provides a little bit of natural PEEP. It all adds up. So that sounds pretty bad, right? But this is where we get to be proactive. This brings us to our final section and to our primary tool for fighting back.
The big question then becomes, when we're faced with this unavoidable drop in compliance, what's our main move? How can we actively make the situation better for our patient?
And the answer, in a word, is PEEP, positive end expiratory pressure. It's a setting on our ventilator that just makes sure the pressure in the lungs never drops all the way back to zero when the patient breathes out. We're basically creating a little pressure cushion.
So how does PEEP work its magic? Well, first, it acts like a little pressure splint, popping open alveoli that have collapsed. Second, by doing that, it increases the FRC, bringing that lung volume back up toward normal. And third, this is the really cool part, it moves the patient onto the steepest, most efficient part of their pressure volume curve. The bottom line, every breath is more effective, oxygenation improves, and the work of breathing goes down.
And just like that, we've covered the whole story, from the basic definition all the way to our key clinical intervention.
So as a final thought, just remember that understanding lung compliance isn't just an abstract exam topic. It explains why we see what we see on the ventilator, it helps us figure out what's wrong, and it guides how we fix it. And if you want to go even deeper, all of this info was drawn from Chapter 19 of Respiratory Physiology. All right, good luck with your revision.